Hello everybody, welcome. Welcome to another session in our Peers Under Pressure series. Many of you will already know us here at OSKA, and of course if you've joined us in previous sessions you'll also know some of my speakers this afternoon, but for anybody that's new joining us, a very warm welcome. So without further ado, let me introduce you to my guests this afternoon. I'm delighted to welcome three experts in their fields. Firstly, a warm welcome to Valerie Dowley.
Hello.
Valerie is an independent tissue viability nurse specialist with many years' experience in both acute and community healthcare settings. She is also nurse lecturer at the University of Brighton Foundation degree for health and social care practice and is now an associate fellow of higher education. I'd also like to welcome back Alison Schofield.
Hi everybody.
Alison is clinical manager and tissue viability nurse specialist. Her current role at Mould Digital involves producing and delivering education and tools for healthcare professionals in all aspects of tissue viability. And she's also worked for more than 20 years in community services as a district nurse and a TVN. She has also led a pressure ulcer prevention team in Bradford NHS services. And last, but by no means least, I'd like to welcome back Anita. Where's Anita?
Hello, can you hear me?
We can hear you now, yes. Anita is OSKA's clinical support nurse, and she has more than 20 years experience in community nursing, teaching and industry. She's got an extensive background in nurse education, pressure area care and negative wound therapy, and she truly believes that education is the key to excellence in care. And I'm Emma, and I will be your chair today. Because we want you to get the most out of today's session, we give you the opportunity to ask the expert in advance. Thank you to everyone who submitted their questions. The nurses have reviewed them in advance and will answer them live as we go through the training. But if you've not taken up the opportunity to ask, please do share your experiences or ask any burning questions in the Q&A function on Zoom to participate in our discussions this afternoon. These ladies really are experts in their field. So with our introductions done, let's get on with our session. Diabetic ulcer or pressure ulcer? That is the question. Anita, let's kick off with you first.
Thanks, Emma. So what we wanted to do initially was just to recap, and I know we do recap quite a bit during these sessions, but this is always a good thing. So we really wanted to go over the definition of what a pressure ulcer is. So taking it from NHS Improvement in 2018, a pressure ulcer is localised damage to the skin and or underlying tissue, usually over a bony prominence, or can be related to a medical or a device, resulting from sustained pressure, including pressure associated with shear. And we know the damage can be present as intact skin or an open ulcer and may be painful. And there are now 7 categories of pressure ulcer. So we know the 6 I'm sure you're all very familiar with from the EPUAP, which is categories 1 to 4, unstageable and suspected deep tissue injury, and we also have medical device related or device related pressure ulcers as well. What I would say with medical device related or device related pressure is that you would still categorise those ulcers according to those EPUAP categories, so 1 to 4, unstageable and suspected deep tissue injury. So one of the questions we were given prior to this webinar was about what terminology we're now using for pressure ulcers. So the terminology we're now using is category. So that was all within the NHS Improvement document in 2018 that they recommended that we use the terminology of category. It is different in Scotland. They are using grade of pressure ulcer, but if you're within England, Wales and Northern Ireland, then category is what we're using. So hopefully that clears it up. And another question we were asked prior to this session was just around how we categorise either pressure ulcers or diabetic ulcers, and are they the same? So in terms of category of pressure ulcer, we've just gone through that, that's the EPUAP categories. But with diabetic foot ulcers, we would grade them differently. So we would use the Wagner diabetic foot ulcer grade classification system. And so that grades your diabetic ulcers slightly differently. So that goes from 0 through to 5, and that looks at kind of depth essentially. So you're looking at intact skin as your grade 0, right the way through to kind of full foot gangrene for your grade 5. 1.5. So I would just recommend that you look at that classification system for obviously more information. Okay, next slide, please. So again, another refresher just over how pressure ulcers are caused. So we're looking at those extrinsic factors in pressure and shear. So if we go over pressure, first of all, pressure is basically a perpendicular force, so it's linear. So it will push down, it will push up, it will go side to side, but it won't bend in any way, so there's no give to it, essentially. So pressure ulcers are basically caused when an area of the skin and underlying soft tissues are placed under prolonged pressure. So that's high levels of pressure, which is over a long period of time. And as you can see from that diagram, that top diagram, you've got your bony prominence pushing down and almost the surface pushing up. And what that's doing is those soft tissues in between are getting compressed. And they're getting compressed between the bone and that surface that somebody is either sitting or lying on. And this over time can include the blood supply, leading to poor oxygen supply to the tissues, causing the tissues to die. So that's pressure, but we know from that definition of what a pressure ulcer is, that when we have pressure and shear in combination, that can cause some really severe damage. So shearing is basically gravity, which is pushing down on the body where there's resistance between the patient and either the chair or bed, whatever surface that they're sitting or lying on. So this results in the bone sliding down and the skin and the soft tissues being dragged against the bed or chair that they are on. So I'm sure we've all seen those patients that we sit nicely in a chair, and then over time their chair is not quite the right height for them, they start to slide down. So that essentially is where we're getting that shearing, where the skin of our back and our bottom stays in the original position from friction, and then we get that soft tissue dragging as our pelvic bones almost get pushed forward through gravity. So shearing is most noticeable when we get postural changes. So it's basically, like I said, where that skin is kind of being held in its original position. So the skin essentially is quite sticky at that point. So next slide, please, Emma. So looking at diabetes and giving a bit of an overview of diabetes, I'm sure you'll know it's one of the most common chronic diseases in the UK, and we know the prevalence is increasing. So it is estimated that there's about 4.7 million people in the UK that have diabetes, and about 336,000 children, under the age of 19 have diabetes, with most children being diagnosed anywhere between the ages of 10 and 14. And more than 5 million people will be diagnosed with diabetes by 2025. That's a staggering amount, and that's only going to increase by 2030 to 5.5 million is the prediction. So that's a lot of people potentially that may end up with diabetic foot ulcers. So next slide, please, Emma. So, and again, I'm sure we are very aware that there are two types of diabetes. So there's type 1 and there's type 2. So type 1 is defined as insulin dependent, and it is an autoimmune disease causing the insulin producing beta cells in the pancreas to be destroyed, preventing the body from being able to produce enough insulin to adequately regulate blood glucose levels. And type 1 diabetes most commonly presents in children and young people, and it can persist into adult life or even start in adult life as well. So it can present at any age, although the incidence we know peak in early childhood, so maybe between the ages of sort of 6 months to 5 years, and again during puberty. And about 8% of people with diabetes have type 1 diabetes, and the prevalence is highest in people aged 35 to 60 years of age. And then, sorry, just excuse me while I just get my notes, because I've got a little bit covering my screen there. And about 90% of children and young people in the UK who have diabetes will generally have type 1 diabetes. So let's go on to the next slide, Emma, and look at type 2. So type 2 diabetes is a metabolic disorder that results in hyperglycemia, so that's high blood sugar levels or high blood glucose levels. And that is due generally to the body being ineffective at using the insulin it produced, also known as insulin resistance, or being able to produce enough insulin. So type 2 diabetes is characterized by the body being unable to metabolize glucose, so that's a simple sugar, and this leads to high levels of blood glucose, which over time can damage any of our internal organs. So it is rising and it is a public health burden, and over 10% of the National Health Service entire budget is now being used up in managing the complications of diabetes or type 2 diabetes. So that's, that's a staggering amount essentially. And males are 23% more likely to have type 2 diabetes, and also those who suffer social deprivation as well. And 77% are more likely to develop the disease than those in those least deprived areas. So next slide, please, Emma. And type 2 diabetes is often linked to genetic factors, to things like obesity, and we know that as a nation we are becoming larger, and we are also becoming more sedentary, and that is another factor involved in that development of type 2 diabetes. We are an ageing population, and unfortunately as we get older, we are more likely to develop type 2 diabetes. And it is also linked to a consumption of energy-dense foods, which again is linked to that obesity and something that we are certainly seeing. And also, when we get the cost of living crisis that we're currently going through, a lot of people plump for those energy-dense foods because it keeps them fuller for longer. And there is also physical inactivity going on again. So we know that people are more inactive, as we get older, but also generally speaking in the population, we are more inactive. And again, that is another thing that's linked to type 2 diabetes. So I'm going to pass on to Valerie now to go into a bit more detail.
Okay, thank you, Anita. So let's look into a little bit more detail around what is a diabetic ulcer. So the International Working Group on Diabetic Foot from 2019, which is the most current document that's being used, defines a diabetic ulcer as full thickness wound below the ankle on a diabetic patient, irrespective of the duration, usually coupled with neuropathy and peripheral arterial disease in the lower extremities. And that was one of the questions that was posed beforehand was, what is the difference between a diabetic foot ulcer and a pressure ulcer? Well, in some ways, the only difference is that it is pressure damage to the foot of a person who suffers from diabetes, whether they have peripheral arterial disease or whether they suffer with neuropathic or sensation disorders. So there isn't, I think often we confuse things by thinking, oh, it's a diabetic foot ulcer or it's a pressure ulcer. It's not. Sometimes some diabetic foot ulcers are caused by an ischemic event in the foot where blood supply is reduced to a certain area, causing that area to become necrotic and die off. But more often than not, they're caused by pressure on a diabetic foot that's unrelieved. And if we think about that, and we think about somebody maybe who has diabetes with an element of peripheral arterial disease, then it's going to take a much shorter duration of pressure to actually cause that the tissue to become devitalized. Excuse me. So worldwide, there's about 26 million people who develop foot ulcers annually, which is huge. And among all amputations associated with diabetic foot ulcers, 83% were major amputations. That means a whole leg below the knee or above the knee, and 96% were minor, which probably means just a digit or a couple of digits or a 4-foot amputation. And both carry a higher mortality rate of up to 70% of patients dying within 5 years. Excuse me. The other interesting statistic is around the recurrence rate of diabetic foot, and it was a bit of extra information I looked up just before we came on, because one of the questions that was asked was, what is the best way to treat a diabetic ulcer that is recurrent? And I'm not going to answer the whole question here, but I think that if we have a greater understanding of the recurrence rates, then we can understand why these things happen. So the current statistics suggest that there is a 40% recurrence rate within a year, and there's a 65% recurrence rate within 3 years. So it is not unusual for diabetic ulcers that heal to reoccur. And part of that is around the fact that we need to, there may be no intervention available to that patient that might improve their perhaps peripheral arterial disease, or they may continue to have neuropathic disorders that cause them not to feel pressure when it builds up. So in this cohort of patients, sort of close observation and preventing foot ulcers is extremely important. And it starts with sort of identifying those who are at risk. And if you again look at the literature, excuse me, it talks about 5 key elements that we need to put in as a cornerstone for foot ulcer prevention. And that starts with identifying the foot that is at risk. So anyone with diabetes may be at risk. They may not all develop pressure damage, but they may, and they may not all be at risk, but there's elements of everything that we've talked about previously about pressure ulcers, such as immobility, increased pressure, maybe comorbidities, ill-fitting shoes, and that we'll talk a little bit more about. The second of the key elements is regular inspection and examining of the foot. So all patients with diabetes should have a regular examination of the foot. And at the moment, it is definitely recommended as an annual review. But if they're at higher risk, that can be as often as every 6 months. The third key element is about educating the patient about their own disease and about what they need to look out for and how they need to access services and not to kind of put things on the long finger thinking it will go away, but also to educate the families and healthcare professions who are exposed to and looking after people with diabetes. The fourth one is about wearing appropriate footwear, and the fifth one is about treating risk factors that can lead to ulceration, and that's things like ensuring we've got good pressure relief, ensuring good footwear, maybe some offloading. Next slide, please.
Valerie, before we move on, we've had a really good question, which seems appropriate to ask at this point.
Okay.
If the individual has good peripheral arterial disease, normal sensation, goes on to develop a pressure wound due to poor footwear, it's a pressure wound, is that correct?
If they are a diabetic, it is a diabetic foot ulcer caused by pressure. And I think that's where things get confusing. It becomes a diabetic ulcer because the patient has diabetes, even though it's caused by pressure. So obviously diabetics, whether they have good circulation, whether they have good sensation, if they have diabetes, it turns into a category of a diabetic foot ulcer because we can't separate them. And I think this is what's really important. People think that, or get the impression that one is a diabetic foot ulcer and the other is a pressure ulcer. But actually, it's pressure damage that has happened on a diabetic patient's foot, which leads to it being termed as a diabetic foot ulcer. I hope that's answered the question.
Thank you.
Okay, so if we can move on to the next slide. So we're going to do a little bit more around the risk factors here, looking at we keep using this asking model, and I think it's really important that we do that. Some people may remember the old skin model that has been around for a number of years, but in 2018, the National Health Service Improvement introduced 2 more important additions to the skin bundle, and that was the A for assessment of risk and the G for giving information. And it's now really been adopted across a range of care settings because it helps to guide prevention strategies, and it helps to look at how at any interventions that are needed to either prevent or to manage. So if we could have the next slide, please. Okay, so again, this is looking at the risk assessment side of things. So next slide, please, Emma. Okay, so why do we need pressure ulcer risk assessment? And this relates to not only patients who have got diabetes, but any patient really. It allows us to detect, it allows us to have early detection of individuals at risk. And I think that's really important. And when it comes to the diabetic patient, we almost need to be extra vigilant because they may have elements that are related to their diabetes that puts them at a higher risk of developing pressure ulcers. And that risk assessment obviously should be undertaken using a valid risk assessment tool. So there are still many different types of tools in use out there. Some of them maybe it's still a little bit subjective, and others may be following, again, the NHS improvement guidelines in moving over towards the Purpose T risk assessment tool. But whichever one you're using, it is about remembering that it is just a tool, that it will give us an element of a tick box or a scoring system that will allow us to make a judgment around where somebody sits in a risk factor. But on its own, in isolation, it shouldn't be used in isolation, because that takes away the whole holistic element of it as well. So we need to use it alongside that holistic assessment and our own clinical judgment, because sometimes our clinical judgment, when we're using risk assessment tools, will say that the patient's risk is different from what the risk assessment tool is actually showing us. It enables us to then take that information and put that into a plan of care, which we can then use and implement. And that helps us to communicate to our colleagues and other carers, because the reality of healthcare out there at the moment is we don't always get to see the same patient every time we're on duty. We might be in a different floor, on a different bay, or in a different area if we're in the community and that. So it allows for good communication. So it allows for other people to see what the plan of care is, what needs to be implemented. It helps us to look after our key resources, not only the nurses and the healthcare practitioners that are working, but also other resources such as pressure relieving equipment or offloading equipment, and how to treat current pressure ulcers. And it's really important to remember that when there's any change in the patient's condition, we should be looking back and reassessing them along with the risk assessment tool and our clinical judgment as soon as we notice that that patient's condition changes. Because again, the reality out there is that when conditions can change quite quickly. So a patient can be quite well one day, and then, maybe they've come down with a little bit of COVID, or they get a bit of vomiting and diarrhea. And because they're already in a fragile physical state, that can actually have a huge impact within hours. So patient's condition can change really, really quickly. So we need to be mindful and on the ball to reassess, because we may then have to divert some other resources into protecting that patient for that period of time. And that makes sure that the right equipment and the right resources are there to meet both the patient's needs and the needs of the healthcare facility that they're being nursed in. Next slide, please. So why are diabetic feet at a higher risk of developing pressure ulcers? Well, again, if you look through the literature, there is a lot of factors. It's multifactorial, and really it can be quite complex to read about sort of the risk around diabetic ulcers and who's at risk, and to try and figure that out. But the research would say that there are 3 key factors which puts the diabetic patient at a higher risk of developing pressure ulcers. So they are the presence of peripheral arterial disease, the loss of foot protection sensitivity, such as peripheral neuropathy, and an elevated level of mechanical stress on the foot, which we're going to go into a little bit more detail of those. But before we move on, when I come back to what Anita said earlier about that question is, what is the difference between our categories of pressure ulcers and how we grade foot ulcers? The image at the bottom is from the Wagner scoring system, and you can see that whereas pressure ulcers have the category 1, 2, 3, 4, and the unstageable DTI and medical devices, the Wagner looks at the foot condition itself. So it has a normal foot, if there's a superficial ulcer, if the grade 2 is a deeper ulcer. The grade 3 is an ulcer that goes down to bone or maybe involves bone, and there might be an element of osteomyelitis in there. Grade 4 is where there's partial gangrene or some tissue ischemia involved. And the grade 5 is where there is a lot of gangrene and perhaps the whole foot involved. So next slide, please, Emma. So let's look at those 3 elements that I just spoke about. So peripheral arterial disease, it's defined as the narrowing or blockage of blood vessels due to fatty deposits, and affects about 1 in 3 people with diabetes over the age of 50. And that's a staggering amount of people, really. There is an increased risk. That risk is 11% of diabetics patients compared to 4% of non-diabetic patients. Of type 2 diabetes developing peripheral arterial disease. So you can see that, you know, type 2 diabetic patients are at a higher risk of developing PAD. And that's up to 50% of patients who suffer from diabetic foot ulcers. Some of the research, Twilley and Jones in 2016, suggested that there is a strong relationship between peripheral arterial disease and the development of pressure ulcers, especially to the heel, which are more likely to present as deeper and more severe pressure ulcers than in patients without peripheral arterial disease. And the reason for that is, as I explained earlier, that once peripheral arterial disease is present, we already have tissue that is having a reduced blood supply. If we then put pressure onto an area such as the heel, it takes far less time for that tissue to become devitalized. And it also means that the area of tissue death is much bigger. And the research is showing that as well. It's important to establish the presence and the extent of peripheral arterial disease through various different mechanisms, such as looking at the patient's clinical history, liaising with the diabetic specialist nurse, who may know more about the patient perhaps than the care setting does, reviewing whether they've seen vascular or whether they've had vascular input, and if not, then they should have vascular input, and through arranging a specialist ankle brachial pressure index test. And for those of you who may not be familiar with it, it's where we use a Doppler machine and blood pressure cuffs, and we sound out a couple of arteries in the foot, and through a mechanism of pumping up the cuff and releasing it, we are able to see at what level the arteries are feeding the foot. And there's a sliding scale of like 1 is normal, but 0.5 would mean only 50% of the blood is going down into the foot. 0.3 would mean 30%. So we're able to tell in a, you know, with through an ABPI how well perfused a foot is. And good clinical practice would suggest that any patient with an element of peripheral arterial disease should have an assessment done on the blood supply to the foot, whether they have an ulcer or tissue death there or not, because then it allows us to use that information to plan care and to perhaps justify putting in equipment such as offloading or heel booties or something else in advance, so that we actually end up preventing tissue death in patients with peripheral arterial disease.
Next couple of questions here,
yes,
Valerie.
sure.
Great opportunity. Would you recommend manual ABPI or automated?
Now that is a question that could be put into a pot and stirred. Personally, as an experienced tissue viability nurse who ran a leg ulcer clinic, I would always suggest manual ABPI, and that is done by somebody who is comfortable and confident with the manual ABPI. And the reason for that is there has been incidences where, the automated systems have miscalculated the ABPI. And certainly even when I was working in the community trust, we had incidences where the automated system would pick up an ABPI that was actually higher than what it was on manual, and did on occasions lead to patients having damage that they shouldn't have got if it was done manually. So it's really, I know that we are all very busy out there at the moment. I also know that things change, and we all try within healthcare to make things easier for clinicians so that they spend perhaps less time doing things and so that they can spend more time with the patients. But in my heart of hearts, I would think, and I would be always advising that if somebody needs an ABPI because they have an at-risk foot, or they have a history that would suggest something like peripheral arterial disease, that we should be getting manual ABPI readings, or that we should be sending them to specialist vascular services that can do a much more in-depth duplex scanning, where it actually looks at the actual blood flow within the thing, and come up with a much tighter picture of what's going on there. So I hope that's answered that. Was there another one, Emma, before we move on?
I think Alison wants to make a point on this, and yes, there is another question.
I just very, very quickly, just to say that there is just been released NICE guidance on automated Dopplers. So if anybody wants to research and read that, they are used a lot more in practice because the speed, time, but all those points Valerie just said, I agree entirely.
Okay.
Thanks, Alison. Yeah, the other question is patients with diabetes and necrotic wounds, would that come under diabetic podiatry services or tissue viability services?
Okay, so if a patient has a diabetic wound below the ankle on the foot, it should be diabetic podiatry, because that's the sort of cutoff point. If there is perhaps a waiting list for referral to diabetic podiatry, you could ask your tissue viability colleagues to step in and give you an interim care plan to help support the patient so that we make sure things don't deteriorate. But obviously sending them to a specialized area is better in the long run, whichever way it is. Somebody did ask that question. I'm just going to quick flick through it. Somebody did ask the question before it about, GP, a nurse, or a tissue viability. And I think that it is really important that we tap into those specialist areas. GP may not necessarily have a huge knowledge around the management of any kind of wound, to be honest with you. So if you've got a diabetic with a foot ulcer, you should be going to the diabetic podiatry. If there's a delay in that referral, then talk to your tissue viability colleagues. And talk to your tissue viability colleagues. I don't know, Alison just put up a message there, but I wasn't sure what that is. Okay, let's move on to the next slide, and I'm happy to take the more questions as we go. So the second aspect of what puts a diabetic person at risk of developing open areas to their feet is that loss of foot protection sensitivity. So it's thought to be caused by nerve dysfunction and cell death due to oxidative stress and inflammation. And due to this lack of sensation in the foot, there is an inability to sense even light pressure. And that lack of sensation on the foot can then lead to somebody loading the foot with really high pressures. And obviously, our feet aren't designed to take high pressures without that sensation. We need that sensation in our foot to keep us safe, because you and I know that if we walk and say perhaps stepped on a stone or got something in our shoe, we would go, ooh, ouch, and we would immediately remove it. But obviously, if there's peripheral neuropathy, the patients don't feel that. And actually, at this stage, I'm going to tell you, hopefully I'm not taking up too much time, but I'm going to tell you a little story about a patient that I had years ago who was a diabetic, and he had both peripheral arterial disease, but it wasn't as severe, but he also had neuropathy. And we had just healed one lot of diabetic foot ulcers on his the pad surface of his heel, when the district nurses rang me and said that he had developed another pressure sore over his small toe bunion on one of his feet. So I went to see him. He was deaf and mute, so we had to find our own way of communicating. But in the end, and they couldn't figure out how it happened, because he'd been very careful. He was doing his best to sort of manage it, and he was always very receptive to advice. So I had a look at his footwear, which was a Kerapede boot, and you know the Kerapede boots, they're the diabetic black boots. So we had that, and I looked at his Kerapede boot, and it all looked fine. And then for some reason thought, have you got a second pair of these? And to which he said yes. And I looked at the second pair, and in the corner between the sole of the foot and the material that came up to cover the thing was the little crystal pack that you get in, you know, the crystal pack you get in handbags and in shoe boxes. So that little crystal pack had slipped down between the sole of the foot and the piece. So when he was strapping them on, he didn't see, and he couldn't see it because he had a little bit of eyesight problem because of his diabetes, and he was walking on the crystal pack and hence developed additional pressure damage. So but he didn't feel it because of that. So it was only when the damage was done and the nurses noted it. So this lack of foot sensitivity can lead to trauma and injury, which the patient can't feel, resulting in changes such as bone deformity. So you might have heard of Charcot's foot, where the bones change because of trauma. And they overcalcify, and so and once the bones start changing, then so does the shape of the foot, and therefore so does the areas in which the pressures go through. And that often results initially in the development of callus. So callus is hard skin over areas of the toe. We get callus on our heels if our heels are dry, and we might get a little bit of callus over our bunions if we wear tight-fitting shoes. But the diabetic neuropathic patients develop callus in almost in places that you shouldn't actually see it on a normal foot. And a lot of you might, have heard stories over the years of diabetic patients who go to maybe a foot health service or, to get their toes done, and then they come back having had some callus removed, and there's an ulcer under there, and they blame the podiatry service, but actually that also would have been there because there's a change in pressures causing pressures in the wrong place. You can get hammer toe, which is when your ligaments tighten in your foot due to reduced oxygenation, and they start contracting, and you get toes that where the mid knuckle is much higher. That's hammer toe. You do get gait change, especially if you've got a deformed bones, so you're not perhaps not walking through the foot as much, and this lack of sensation often prevents diabetic patients from responding quickly to abnormal stresses because they can't feel it. They don't necessarily think it's happened, and I think this is one part where that key element of patient education is so important about, reminding the patient that they need to look at their own feet. However, whether it is having somebody else look at it, a family carer, or whether it's using a mirror to regularly see their foot. Next slide, please. So this loss of foot protection sensitivity can lead to patients wearing ill-fitting footwear, which is one of the problems where they get sort of maybe friction forces where they shouldn't be, or they don't feel that the foot is too tight, or they don't feel things in the foot. They might notice rubbing or pressure over bony prominences. They might develop trauma from debris in the footwear. So that story I've told them, we all know the story of the diabetic with neuropathy who turns up in A&E with a nail through their foot because they stood on it and didn't feel it and somebody else noticed it. Chronic pain also, because of the changes in the foot, even though they can't feel the sensations in the foot, they may be able to feel the changes deeper within the tissues and within the bone structures, which causes pain and might reduce mobility. And there's a delay in recognizing signs of infection. And again, because of the lack of foot sensitivity, they may not display the same characteristics of infection as somebody who's got a non-diabetic problem with their foot. So often an infection in a diabetic patient may be raging, but the patient is actually feeling well and not showing huge signs of infection. And that means that they fail to relieve pressure over the heel areas due to that lack of sensation. So it puts that foot hugely at risk. Next slide, please. And it's important that neuropathic ulcers, they mainly develop on the plantar surface of the foot. So you can see in the picture how that foot has changed in shape because of neuropathy. That's also a short-cut foot. So you can see in the mid area that the bony prominences and the bone structure has changed, causing a callus to build up and changes there. Whereas the ischemic or the patients that suffer from peripheral arterial disease, the ulcers are more common to develop on the tips of the toes, maybe because the shoes are too tight, or on the lateral borders of the foot, or maybe over the ankle bone if they wear higher shoes. So it's important to determine the depth of a foot ulcer because it may have callus or necrotic tissue, and that may need to be debrided. And what the most important thing here is that debridement needs to be undertaken by an appropriate trained healthcare profession. So coming back to the question about should we be sending them to podiatry or not, the answer is yes, or if you don't have that podiatry service available to you, or there's a delay in referring, then to tissue viability, who may be able to do the debridement, or to the vascular service if they've not been seen by vascular before. And obviously the vascular service is a really important aspect in the whole assessment of the foot, especially if they're relatively new or it's the first time they've had maybe a foot ulcer. Next slide, please. And the last part of the three factors is about that increased level of mechanical stress, which we have kind of tipped on in the other slides. Plantar pressure, plantar being the undersurface of your foot, it forms a vertical component of the load experienced through the foot during normal walking. So it helps to spread out the load as somebody walks through from heel to toe. Patients with peripheral neuropathy and lack of sensation, when you look at the research, it shows that they experience elevated pressure in that plantar region of the foot, resulting in tissue inflammation because that tissue is not used to and is not designed to take that elevated pressure. It also causes tissue stress and breakdown, increasing the risk of callus, and underneath the callus then for ulcer formation. And to protect their feet, patients should therefore not walk barefoot, especially if they have no sensation or they have changes in the gait, or they shouldn't walk in socks without shoes. They should be very careful about their choice of footwear. And so, well padded slippers and shoes will protect that and reduce the sort of elevated pressure in that region. Bone deformities should be looked at by podiatry because they can result in minor trauma. And also, if patients are experiencing deeper pain within that foot, they can then tend to guard that area, and that may end up resulting in limited joint mobility, which then results in that abnormal biomechanical loading, which produces that high stress. So they're the three main factors that put diabetic feet at a greater risk of developing ulcers, whether the ulcers are due to the peripheral arterial disease or due to increased pressure. Okay, I think I'm handing over to Alison, perhaps.
I think we are. Thank you, Val.
No problem.
That was great. Really, really in depth. I'm not sure everybody. We've got so many people watching today. It's amazing. So everybody was watching with fascination there. And yes, so obviously we've now learned about what the kind of differences are, and how, you know, the underlying etiology, and risk factors, etc. So when it comes to inspecting the skin, and we know obviously this is a big part of the asking tool that we use. Next slide, please, Emma. And so the feet, are no different. And sometimes it's the kind of extremity areas that sometimes get missed. So do take socks and shoes off, and and check the feet, not just checking the bottom when it's kind of repositioning people or taking people to the toilet and things. It's really, really important. And if that person has diabetes, we know they have that extra risk. Just to say, because there's people been asking sort of questions, and on the back of where Valerie answered the question about is it a diabetic foot ulcer or is it pressure ulcer, and and what was the cause of that. If in all wounds, no matter what they are, we have to ascertain the root cause of it. What has caused it? What's underlying? What are the risks? Did we address the risk? Did we put interventions in place, and could we have prevented it? Even though the person has diabetes, it doesn't mean to say, oh, well, it would have occurred anyway, because if there's unrelieved pressure. So do you report it in your reporting systems, whether it's Datex or your other systems, if you're in a care home setting? Yes, you do, if the root cause is actually pressure. And yes, we still do root cause analysis. And obviously this is part of all that information for us to look at, well, this was the risk factor, and did we identify that in our assessments, and then did we address it with the intervention? So I hope that sort of cleared that up a little bit. So when we are assessing the skin on the feet and the heels, and generally on the body, how do we do that? What we're looking. So remember, we have a best practice statement on addressing bias in dark skin tones. So it will be different depending on the tone of the skin. So a light and pale skin tone, we do the blanchable erythema test. So when we have inflammation due to a pressure that's there, or if it's the issues with from the diabetic foot ulcer, peripheral arterial disease, then the first signs of inflammation are when the cells start to die. So we get that on a pale skin, that reddened area, and it can blanch when we press it with that finger test. And also then on a dark skin tone, we know we don't get typically that red area, but the area may look like a purple colour or a bluey colour. But the important thing is to check. I just want to these are the points from the best practice statement on a checking of skin. So what is the wound, peri-wound skin like in comparison to the surrounding skin? Are there differences in colour? Does the skin feel warm to touch? Are there changes in temperature? Does the skin feel spongy or firm to touch? And on heels, you often do get that, where it'll feel spongy or boggy, we sometimes say. Does the skin feel shiny or tight? Is there signs of swelling and inflammation? Are there changes in the texture of the skin and the underlying tissue? What's the overall integrity of the skin look like, the condition? And is the changes in sensation, pain, and itchiness? And as Val said, obviously people with diabetes may have neuropathy and loss of sensation. But we're talking about the visual signs, and even before we can see that, there is something called subepidermal moisture that can occur with unrelieved pressure, and it's causes further mechanical loading on the cells and tissue. So that gives a rise into the interstitial pressures. So the cell damage can be visible under microscopes in just a few minutes. So that's really fast. So that's why we have to react. We have to put interventions in place for these people who are at a very high risk. but it takes hours of sustained loading for that damage to be visible to us, like on the signs you can see on the pictures on the screen. So near the bony prominence areas, such as on the heels and other areas on the feet, we get higher stresses and strains than those near the surface, so that deeper tissue damage might be there before it's visible to the naked eye. And on a darker skin tone, it might, because the soles of the feet are always paler than the rest of the skin on our body. So use another part of the body, similar part of the body, so heel to heel for comparison. Obviously, if somebody's had an amputation, you can't do that. But somebody asked the pre-question as well, where do we look for a diabetic foot ulcer on the feet, as we would do with, it could be any part of the feet, underneath, sides, toes, on top, and on the heel. For the points of pressure, we know it's not just bony prominences, but could be a device related pressure ulcer, like a tight shoe strap or something like that. So every little aspect of the feet, so below the ankle, every point of it, we check, and looking at the difference in pigmentation. Next slide, please, Emma. So assess daily is good advice, and remove all the elements that I've said. Now splints, that's a good one, because people often say, oh, should I, if somebody's come out of hospital with a splint or device, should I be removing it? You should be given advice on how to do that, but if you haven't, then maybe to follow that up. Obviously, if it's like a plaster cast, then you can't, but if patients are saying or showing signs of being uncomfortable with a cast on, I've had this with children before, where they're with learning disabilities, where they've shown signs of pain, cast is removed, and they've got category 3 pressure ulcer to the foot or to the heel. So the signs of in the skin that we've mentioned. Look for the kind of blisters, and Val mentioned about the callus build-up in people with diabetes, which then can be prone to cracking, and then that can lead to diabetic foot ulceration. Check between the toes. Classic for getting soggy and fungal type infections. And if just ask those questions about the skin. How is it feeling? Is somebody in pain? Because if they are feeling pain in their heels, then they need to have them offloaded as soon as possible. So we educate the patients, we give advice and onto how, what can they look for. So show them as you're doing it, do a demonstration of where to look and what to look for, the different signs and colours and temperature, things like that, because there is a massive increase, risk of increase in amputations for people, 2 to 3 times more likely in people who have diabetes, and a high mortality as well. So we need to be reducing that. Next slide, please, Emma. So the absence of symptoms in a person with diabetes doesn't mean to say they don't have foot disease. We can't always see everything, can we? And that neuropathy, that peripheral arterial disease, that could be all there underlying before we even see signs of an ulcer, but react to risk, can't say that enough. So it's important for that history, to get the history of a patient who's, your first assessment, they're initially admitted to your care setting. We need to get all that information. If we have electronic patient records, fantastic, because there should be things on there we can refer to. So are they describing different types of pain? What is that like for them? Is it that their pain is when they're walking up a hill or upstairs, that's worse, and in the backs of the calf? Do they have to hang their legs out of bed at night because it's a relief for that, which is called intermittent claudication, and it's just like a narrowing of the arteries. I remember my granddad had this, and he always said when we went to Scarborough on holiday, oh, it's too hilly, because his legs were so painful walking up the hills there. Palpation of pedal pulses can be done, but it's not that easy for people outside of podiatry really, or in specialist care. So you need to get somebody seen by a specialist, and then they can sound out those pulses with the Doppler. And there's also assessment using the monofilament devices, which is just like a touch test to see if somebody's got sensation. But again, you probably won't have those available unless you're in specialist practice. You can touch the tips of people's toes with the tip of your index finger 1 to 2 seconds, and just to see if they can feel that or not. But you know, must be reviewed. There's in the National Wound Care Strategy Programme, there's guidance for the lower limb. There is a separate guidance for the foot now, which has been out for review on draft. So we're waiting for that to come out, and that should have, you know, that separate information there for us as well. But there's lots of national guidance all about the diabetic foot, and you know, what we should be doing with that, and who should be seeing them. So there's red flags in the national guidance, and anybody who is diabetic showing any signs of skin integrity break, ulceration to their foot, should be seen in community within 1 working day. If they're in hospital within 24 hours, we class it as an emergency because it can rapidly spread and they can, you know, develop amputation. So important to get them for that 12-monthly review, if not more, and to get nails checked, etc., etc. And yeah, just to be aware and mindful. Next slide, please. I think I'm handing over to Anita. She's down there with all the equipment, look.
Thanks, Alison. So yeah, so this obviously going through the asking bundle, we're now going to be looking at surface selection and use. So next slide, please, Emma. So just to reiterate over device-related pressure ulcers again, patients with peripheral neuropathy will have that reduced sensation, and also patients with peripheral arterial disease will be at greater risk of developing pressure ulcers from using devices. So it's just about ensuring, as both Valerie and Alison have said, let's make sure we're inspecting underneath those devices, and making sure that we are looking at those feet in particular. We don't want them to be out of sight and out of mind. So, you know, if we can look under dressings as and when we remove them, or if someone is complaining of pain and soreness, then let's take them off, let's have a look, let's take shoes, socks, slippers off, all of those things to have a good look at the feet. And you can see that lower picture with compression hosiery as well. Again, please remove those and have a good look. So next slide, please, Emma. So again, Alison and Valerie have both looked at this already, so it's about recapping over this just because it's so important. When we're talking surfaces, we're not always talking about support surfaces in mattresses and cushions. We're talking about anything that potentially could be sitting against somebody's skin. So for diabetics and looking at the feet, we might be thinking about footwear. Now, it is really important, as has already been said, that these patients are reviewed by diabetic podiatrists, because they will look at the walking gait, they'll look at the structure of the foot and the footwear, and this can all be assessed as appropriate. But the things that we can offer, the advice we can offer, is about just education on avoiding tight footwear, or any footwear that has any rough edges or seams that can compress and dig into the foot. If there is lower limb edema, then again, we need to be thinking that actually that foot might swell throughout the course of the day. And so is that footwear appropriate? Can it be altered? Can it be adjusted? Or is it just going to become tight fitting over time? And as Valerie said about avoiding walking barefoot and not walking in just socks without any footwear on, and think about the thickness of the soles as well. Certainly with slippers, you know, we really want a nice thick sole, as that is generally preferred. So next slide, please, Emma. So when we're talking about pressure relieving equipment, if we're talking about support surfaces, ideally what we want to start looking at is a support surface that's going to provide good levels of immersion and envelopment. So I'm going to be talking through a couple of products from OSKA in just a moment. But In terms of general terms for good pressure ulcer prevention, we want to be looking at things that give good immersion and good envelopment. So that immersion is sinking into that surface to increase that surface area so that we can overall reduce those interface pressures. And the interface pressure is just the pressure that builds up between a patient's skin and the support surface that they're sitting or lying on. So we can reduce those interface pressures. We can't reduce those internal pressures without doing that. And we know the internal pressures can be around about 3 to 5 times greater than the interface pressures. So good immersion is really going to help support that. Coupled with that, however, to really increase that surface area, we want to envelop that product around them as well, because the more body contact we have with the support surface, the lower we can get those interface pressures. So we still need to be thinking about regularly offloading. So we will need to be thinking about repositioning as well. So whatever support surface somebody's on, we will still need to reposition. And the selection of your support surface really needs to be on both your risk assessment, but also, like Valerie said earlier, your clinical judgment. That's really important, because that's going to give you much more of a holistic look at a product and be able to get the product that's right for that individual. You know, so I think quite often we see patients that might be deemed as high risk for getting put on air mattresses that aren't always appropriate, because they might sink too far into them and then they can't move. And actually what we've done is immobilize someone instead of encouraging the mobility or that movement they might have on a support surface. So we do need to think about selecting the right surface for somebody. So obviously mattress features are really important. So I want to talk you through a couple of products from OSKA. So obviously, this is just a demo mattress, so just to be aware that this mattress I'm about to talk you through would normally be the same size as the surface beneath it. But this is our OSKA Series 2 mattress. So I'm not going to go through the whole entire mattress today. It's just about looking at the foot area and those key features that will help benefit the vulnerable heel. So with the cover of the mattress, the cover is a really, really strong cover, which is great. But within that, it's multi-stretch. And the reason we have multi-stretch covers is so that the cover moves with the patient as and when they're moving. So if those feet are moving, that cover isn't going to stay static, where it would then work against the skin and cause friction and shearing. It's going to be moving with them, and that's going to help reduce that friction and shear force. The cover is also moisture vapor permeable, so the air can circulate through the cover, because what we don't want to do is get this heat build up where the skin will start sweating. So if we can help reduce that heat build up through that vapor permeability of the cover, then again, that all helps to protect that vulnerable heel area. And I don't know whether you can just about see that on screen, that the foot end of the mattress actually tapers down. So it just tapers down just to start to reduce some of the pressure beneath that heel. But more importantly, inside the mattress, there are actually 2 layers of foam. Hopefully you can see that there. So we've got a base layer of foam, but then we have this top layer. And this top layer is really important because it is called our aerolite foam, and that allows air again to circulate through the foam. So it all helps to help with that skin microclimate. But the really good feature of this is that we can actually fold the foam back on itself. And if we were then to zip the cover back over the top, what we then get is a heel offloader, inbuilt heel offloader. I don't know why I'm using my hand when I've got my trusty heel here. So let me show you. There we go. So you can see that heel is completely offloaded with the support coming back down the calf there. And so that's going to just help support with offloading of that heel. So the Series 2 mattress, because it is a high-spec foam mattress, can be used for high-risk prevention, but up to and including category 2 across the body. But if we then go and use the heel offloader, because we're taking the pressure away completely, if you've got category 3 or 4 ulcers on the heels, then you can use this mattress as long as you're obviously using that heel offloader to help with the management and treatment of up to category 4. So that's some of the special features of the Series 2. Just going to do a little repeater moment and move this one up. There we go. So then we've got our Series 5 mattress. So our Series 5 mattress is it's a high spec mattress. It's an air mattress. And it is a lateral tilting mattress. So there is a lot more information on our website, so I would encourage you to go there to look at the features in terms of the lateral tilt. But like I said, we are looking at the heel zone area today so that I can show you how that supports the heels in terms of diabetic heels. So again, the cover has exactly the same properties as your Series 2. So it has that multi-stretch, that vapor permeability, and you can see that that heel section just starts to slope as well, just to start reducing some of the pressure on the heel. But if we open the mattress up, hopefully you guys can see this, we've actually got different layers of different sections of foam in the mattress, and what we have is foam with air cells underneath. That's just to help with comfort and stability of the product. But we've got different types of foam. So we've got much more of a firmer foam underneath the torso, slightly softer at the head end, but where we really get a lovely soft foam to really immerse and envelop those heels is within this heel section, the foot section. So not only does it taper off, but we have this really immersive enveloping foam just to really try to reduce those interface pressures on that vulnerable heel area. Again, that foam has the ability for the air to circulate around it to help with that skin microclimate. And you probably noticed on the undercover here, we've got these sort of pink sections. Now these are our anti-shear zones. So earlier when I was talking about the cover being multi-stretch and helping to reduce those shear and friction forces, these sections are going to actually do that even further. So we're going to reduce that the ability of friction and shear forces to build up under that heel area. These sections are in 3 sections. So we've got them over the vulnerable heel, the sacral area, and the shoulders again. So 3 vulnerable areas in terms of pressure damage. But if I just hopefully show you on the screen, where we've got these anti-shear zones, the cover is a lot more, it moves a lot more under that heel to move with the body rather than against it. You will still get some movement where you haven't got those anti-shear zones, but in those vulnerable areas, you can see how you've got much more movement to support the heel. So there's just some features of these 2 mattresses. Like I say, I would encourage you, if you are interested, to go to our website and have a look, or put in the chat if you'd like some further information on the 2 mattresses following the webinar. So I think I might have one more slide to go through. So I would just ask to be removed from the spotlight. There we go. So next slide, please, Emma, and I'm just going to ask to go along. There we go. So obviously support surface is the one thing, but there are other products that we can use. So obviously we can use boots to offload heels as well. The boot that you can see on the screen there is a product from OSKA. So this is a nice breathable fabric boot, which has like a quad cell technology, which just helps to stabilize the foot. But there are lots of different products out there aside from features of mattresses that you can use. So yes, there are boots, there are wedges that you can put in the bed. What we do try and steer away from is using pillows, because over pillows to offload the heel over time, they go down quite quickly. So try and steer clear of those. But if that's the only thing you've got to hand at that very moment to offload the heel, then use it. But I would just encourage you to then find something as an alternative to support the heel more long term. Okay, I think I'm handing back to Alison.
Yes, thank you, Anita. That was a fabulous demonstration. I love innovation. It's fabulous, isn't it? So I'm just going to take you through to the end now, through the last points of asking. I'm mindful of time. I know we'll probably still have some more burning questions coming in. So next slide, please, Emma. So we're on to the K for keep your patient moving. So all patients at risk of pressure ulcers should be repositioned unless otherwise there's a contraindication to doing that, which probably would be people in HDU units, ICU, and people at the very end of life. So follow the protocols and pathways as according to that, and that's within national and international guidance. So obviously we're all different, aren't we? So all our individual anatomy varies. So what provides good offloading for one person might not be effective for another. Somebody mentioned in the comments there about with the series 2 and said, oh, well, if somebody kind of curls up, then their heels are not offloaded. Well, no, they're not. Somebody who might have contractures in their legs, that obviously they're not going to be, have their legs been able to straighten out and things like that. So you have to, work around the individual person. But there's so many things now to support all eventualities. So looking at the profile bed itself, one of the functions of the bed is that it can maintain optimum positions for people. So when we are, say like if somebody's coming to be sat up in bed, we have to look at what does that bed do, and you've got your device there to put into the various positions. So we want to make sure that we raise the foot end a little bit first, the knee break, and then raise the head point up, because otherwise the patient will just slide right down that bed. The heels will travel. You can see it happening, you can measure it, and then you will cause that shearing on the heels, and they might be then pressing and touching the footboard on the end of the bed, causing pressure ulceration that way. There's a nice demonstration of that with the head and the knee break in position there. So you can do both together or do the knees first. Avoid raising the head of the bed above 30 degrees, because that causes, pressure on too much pressure on the sacrum and coccyx. And encourage position changes. We have nice guidance. It tells us, repositioning, but again, that is individualized. We always have that conversation about, well, what at night, people are sleeping and things like that. But if somebody can change the position themselves, and encourage somebody to do so every 15 to 30 minutes. If they are diabetic and with the wrist to the heels, really, really regular movements. And remember, in the beds, are the sheets creased and wrinkled? Any zips, buttons, seams, tight clothing, things like that, all can cause pressure damage and damage to the feet if they've got that risk factor. And don't let people sit in the slings in chairs unless they're specifically designed materials to do so. And let's be using our slide sheets when we're moving and handling people, and make sure that slide sheet goes the whole length of the way down to the heels. Otherwise, use an apron out of a dressing pack or something like that, something slippy. So if you're moving somebody back up the bed, then the heels are not, we're not getting that shear, they're being protected as well. Next slide, please, Emma. So incontinence, we know this is a great risk next slide, please, Emma. We know it's a great risk if somebody is incontinent of both urine and feces, of them developing pressure ulcers. So how this affects people in people who are diabetic is they have 70% greater risk of developing urinary incontinence. So we know from research that urinary incontinence in people with diabetes tends to be a progressive condition. So it can cause problems in the daytime, and also wanting to go to the toilet more at night time. And obviously if somebody's then got mobility issues and other comorbidities, then that can result in somebody having incontinence episodes. And we know then that because of the like enzymes in feces and the pH of urine, that can excoriate the skin and cause moisture associated skin damage or incontinence associated dermatitis. So causes for urinary incontinence in people who are diabetic can be that they've got a high body mass index, their blood sugars are uncontrolled, so they're having hyperglycemia attacks, and that their immune system is affected because of their condition, and it is lower too. Other reasons might be, childbirth, multiple births. It can affect the pelvic floor and cause that in, general population anyway. And if somebody is constipated, it put extra pressure on the bladder, can cause that. congestive heart failure, and the mobility I mentioned, and that mobility might be directly as a result of their neuropathy, or they might have had toes, partial foot or leg amputations because of their diabetic neuropathy or PAD, and also types of medication can cause incontinence as well. So we need good hygiene routines in place, washing, pH balanced soaps. There are cleansers, good barrier creams. There's many, it depends what's used in your area on formularies. Which, you know, there are continence pads. People need continence assessments for that. Don't just do a reliance on pads. We need toileting regimes. There are sheaths, so there's many things. So again, locally, there'll be specialist continence teams hopefully in your area as well. Next slide, please, Emma. Nutrition, and you know, I always say this is arguably in wound healing and tissue regeneration and repair is one of the most important factors. And with people with diabetes, in type 1 diabetes, it's important to monitor their carbohydrate intake to make sure that they have a stable level of their blood glucose. And people with type 2 diabetes, it might be that they have to consider weight loss to lower blood glucose levels. So we know there's a national epidemic of obesity. It's talked about in all the media and everywhere at the moment. And obviously that comes hand in hand with the metabolic disease, which is the umbrella where diabetes is, along with cardiovascular disease. And obesity can be one of the causes of that. So now in the NHS, we have in the primary care centres, we have health coaching, social prescribing, where somebody can be referred in to these services to help them with the lifestyle factors of their, you know, kind of exercise and nutritional support. Contrary to a lot of belief, there isn't a special diet for people with diabetes. It is about looking at the Eat Well NHS food plate, all the food groups, and having a very varied diet and taking elements of those. And malnutrition can be common in patients with diabetes and chronic wounds. So that could be of a person of a very low weight, or even of a high weight. You can be malnourished and have obesity too. So it's about us doing those must assessment, those screening assessments that we all do in all our practice and service areas. And people often ask us about, well, if somebody's got a pressure ulcer or they've got a wound, then what about using supplements? So we have some guidance that says not to use supplements, but we should follow food first as a preference. But if the European Pressure Ulcer Advisory Panel say if somebody has if they're impaired, their nutrition is impaired, where they cannot eat, they've got swallowing problems, etc., then supplements will be considered, but under the care of a dietitian or a specialist for extra nutrition and protein. But again, that's following local protocols. But it's about the macro and micronutrients. Next slide, please, Emma. So the micronutrients include all our vitamins and minerals, and we'll get that from our fruit and vegetables. And our macronutrients are our carbohydrates, our protein, our fats, our fibre. So, we should all follow this, really, shouldn't we? Take elements of this. So the diabetic person is not any different to that. I watched a really good program this week on Panorama. You might have done too, about ultra processed foods and how that affects our health and body. So if we can look at what that is and try to avoid that, and also looking at an anti-inflammatory type of diet, which this covers all of that too. So regularly screening of those who are at risk of malnutrition, and also ensuring that people are in monitoring their blood glucose levels as advised under their diabetic specialist, and not forgetting the fluid. And even if somebody is incontinent, they still need regular amounts of fluid. If you're a diabetic, obviously fruit juice can be full of sugar, and those types of drinks. So obviously water, it might be tea, coffee, but not too much caffeine. So somebody's just said, why are supplements not recommended? It's not that they're not recommended, it's that we should go food first. It's follow the NICE guidance of when we should be, but go on, go under the support of our dietitians and nutritionalists for that if they need a referral. Okay, next slide, please. So this is just saying if somebody has a big wound, a big pressure ulcer, they need extra requirements of protein in their body, extra energy through calories and fluid and the micronutrients. So again, just if you're totally unsure, get in touch with your local team. Tissue viability nurses might be able to help support you with that as well. Next slide, please. So giving information, Val talked a lot about that, of how to do that and what to say and what, it was added to the asking framework when we made it asking in 2018. I was part of that working group. And it's just to make sure that we are passing that information on and the ways that we do that. For education for diabetic patients is so essential, and good foot care is the key to that prevention of both diabetic foot ulcers and for pressure ulcers as well. So whether we do that in leaflet form, now we've got the world of technology, so it could be videos. Around the country, there's teams doing all these innovative things about that, and apps and things, so keeping in touch with patients kind of remotely and things like that. So it's just making sure that all that information is given to patients, family, and to other healthcare professionals like all us as well. And next slide, please. So determine, so I think Val's covered most of that as well, about the given information, about, and just to be mindful if somebody has visual impairments or physical inability to check their own feet, who is going to do that for them. So we need to make sure that's going to be done, about that good hygiene regime, washing the foot, and drying well in between the toes. Yes, people can use emollients to moisturize, and thinking of callus on heel side of the foot, but not between the toes. We don't want them to get too soggy. Don't advise people not to put their feet against heaters or put hot water bottles in the bed on their feet on them. Seen some horrific burn injuries due to that. So let's avoid that. Okay, next slide, please, Emma. Oh, let me just move that poll. So wound healing, there were a couple of questions about wound healing in the pre-questions that were sent in. So hopefully this should probably answer some of that for you. So that when a person who's diabetic, any wound they get can be delayed just because of their condition, because they do get altered wound healing phases and responses. You can get the vascular changes that Val talked about. They're more predisposed to the risk of infection. Sometimes the infection in a diabetic foot ulcer or may not be as apparent as it is in a general terms of wound infection. So we get we get a reduced hypoxia, so a lack of oxygen in the wound bed, and in that phase of wound healing, when we get that, when we get the new blood cells forming, what we call the proliferation stage, that's not activated. So, and then the fibroblast cells in the wound can't produce collagen. And so that impairs that healing part stage of the healing, and also it allows more bacteria to get in there, and then that will proliferate and grow, so more risk of infection. The blood vessels also thicken, so that reduces that inflammatory immediate response when we get that clotting and that cleanup phase of phagocytosis. So we get in a prolonged inflammatory phase, and we know that from chronic wounds, if that is prolonged, then more likelihood for delayed healing and more complications. The bacteria feed on that increased glucose that we can get with hyperglycemia, so we get rapid infection spread. and the necrosis and slough become a problem. So we need that regular manual debridement if there's an ulcer there, and often that will be done under the care of a specialist. Because it will often be a sharp debridement. Yes, there are products that we can use to do that manually. You know, any of us can be trained to do that, but if a sharp debridement, need to be trained and specialised in that. And then once that remodelling stage, once the wounds have healed, that maturation stage, we know it can take up to 2 years for tissue strength to become full, but we can get reduced tensile strength in people who are diabetic, so they are at risk of a further breakdown of a DFU, or if there's unrelieved pressure there as well. Okay, so I think that's might have covered that for those people who are asking. And next slide, please. I think we're there.
We're there. Wow.
5 minutes for questions.
Wow. Well, we've answered quite a few as we've gone through this session. Let's pick up another couple. Another really good one. Where does a deep tissue injury classification stand? Would this be treated the same as an open wound, i.e. below the ankle of a diabetic patient? So it's a DFU, although it is not an open wound.
Yes. So it's like if we say a leg ulcer is above the ankle, below the knee, a foot ulcer is below the ankle onto the foot. So yeah.
Okay. Is the roadmap in providing treatment different from leg ulcers, and what about classification of wounds?
The road also, like they kind of wound care pathways and things like that. So yeah, we have pathways for leg ulceration management with compression and things like that. Again, just look locally what's in your area, look at the national strategy guidance of, I think you're probably talking about treatment. Can you apply compression if somebody has pressure ulcers to the foot, or if they have they're a diabetic and then have ulcers to the legs? Yes, you can, but it needs that full assessment and obviously that care plan and guidance under your competent people and your specialist people with that. In some places they'll have a separate pathway for the foot. In podiatry they will have that, and that might transfer over into other services. So just ask and check what's happening in your area.
Alison, I also think it's important to just, because another question came up about that, about managing diabetic leg ulcers. I think that just somebody can have a venous leg ulcer and be a diabetic. So I think it's important, mostly we were talking today about below the ankle and on the foot. If it's a patient who has a leg ulcer who is diabetic, as Alison said, it is about going through almost a similar pathway as you would do for venous leg ulcers, do an assessment, a Doppler ABPI, and if their blood flow is good enough, they would then have the same treatment in compression, perhaps reduced compression or hosiery. You just have to be mindful that obviously the risks if things are too tight or if stockings aren't fitted properly or measured properly, there could be a small increase in risk around their bony prominences. But leg ulcers are treated kind of in that same pathway, because part of the problem would be the venous insufficiency as opposed to the peripheral arterial disease.
And if you can't if a Doppler can't be done because somebody's got bigger legs, or they pulses can't be heard, then there are toe Dopplers that will be done. That they do them often in podiatry and in specialist leg ulcer clinics, and tissue viability can have access to those as well.
Thank you, ladies. Well, as anticipated, lots and lots of questions. If we haven't got to your question this afternoon, we will come back to you. We'll take it off air and come back to you one by one. If you've got any questions, please do reach out to the nurses. They are more than willing to answer your questions. We have a Facebook group of pressure care champions and a quality improvement network. So if you want to join that group, which these ladies are a part of, where you can ask questions and get expert advice, just look for OSKA Pressure Care and ask to join the group. I think, again, it's been such an insightful session. Lots and lots of questions, as I said. the session has been recorded, so you can all go back and watch it on demand. We will be sending that link out next week, along with the training takeaways, a copy of the slide deck. You will all get a certificate, which again will come out to you next week. So bit by bit, we will start to drip feed all that information out to you. The next session coming up is in July, and that's the 12th of July. And what we're doing is addressing or reducing the inequity in darker skin tones. So 12th of July, 2 till 3:30, that link will come out. And then again in October, we have got Managing Skin Change at Life End. So 2 more specialist sessions. So I think all that leaves me to do today is say thank you, ladies. Thank you, Valerie, Alison, Anita. Another great session. We hope you've enjoyed the session. If you want to ask any questions or you want to trial any of the equipment, reach out to us at nurse@oska.uk.com and we will get back to you. In the meantime, have a great evening, and we look forward to welcoming you back in July. Thank you.